Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Today in GasGasGas, we're going to talk about volume of distribution. I remember that this originally really bamboozled me because it seemed as if it didn't really fit with reality. And then I realised that it doesn't fit with reality because actually it's a concept and a crude pharmacological mechanism for thinking about how drugs fill people up to varying degrees depending on the natures of the drug. So volume of distribution is a concept, it's not a reality. Very important distinction. It is a useful tool, however, because it allows you to think about how these drugs equilibrate throughout a human being, and these situations occur with volatile anaesthetics, opiates, propofols. Any drug ultimately distributes throughout a human being in some way, shape or form, and understanding that is important to its use. So now that we understand that this is a concept and not a reality, we can create our own mechanism with which to think about it. And I initially think about these as a series of vessels within a human being. I think about the shot glass volume, the pint volume, the bathtub volume, and then the reservoir volume, i.e. really, really big. I then think that each drug has a particular vessel that it likes to fit into, i.e. its volume of distribution, and that each patient ultimately is a mix of differing vessels, depending on if they are an Olympic swimmer, lots of muscle, not much fat, or an Olympic eater, still a fair bit of muscle to carry the weight, but a lot of fat with which drugs could soak into. These concepts, these vessels, somewhat relate to the patient. So a shot glass, think about that as the patient's plasma. The pint glass is their extracellular fluid. The bathtub, it's all their fluid, including intracellular fluid. And in the reservoir, the patient's adipose tissue. This is one way of thinking about it. You also might be tempted to divide it down into actually individual organs and their tendency to take up agent. That becomes more important when thinking about pharmacological models of drug distribution, i.e. TIVA. And that's where volume of distribution is really important in understanding, because then you've got to think about those fiddly models. More fudgery here and fudge factors. Volume of distributions don't correlate directly to any particular physiological volume in your human being, in your dog, in your cat, in your life form, because drugs dissolve and soak into varying vessels at different rates. Remember, we're talking about these vessels as volumes, not the patient's blood vessels. We're not yet into the meat of it, in that we need to think about the factors that influence the volume of distribution. I mentioned muscly people, fat people. You could also say exceedingly slim, cachectic people, old people and babies. It's important to consider how the drug might naturally dictate its behaviour throughout the patient, i.e. the lipid solubility of the drug, the molecular size, if it's charged, what its pKa might be, and subsequently how it might spread around people, and the plasma protein binding characteristics of the drug. As we mentioned, there are human properties that influence how the drug distributes throughout the person. It's also to think about pathological states that might influence drug distribution throughout the person. We mentioned cachexia just then, but also if patients are particularly soggy and water burdened, i.e. those with heart failure, those with liver failure, or urinally impaired patient on ITU who is just about to go on the filter because they're just one big human puddle. And you could think about the weightlifter with a huge amount of muscle mass, and things might behave a bit differently then, but it's probably less of a thing. So I hope now we've got a bit of a grasp that volume of distribution is a fudge concept that goes on to think about other things in greater detail. It's influenced by the characteristics of the human as well as the characteristics of the drug, and to also say that the units of volume of distribution also confuse the crap out of me, because it comes in either a large litre number or a small litre per kilo number. And it took me a while to figure out that they're one and the same, but the thing perhaps like 30 litres per kilo, for example, as a random number out of the air. That's an indexed volume of distribution to the weight of the patient, which might make it a bit simpler to comprehend. A few quick examples of drugs with different volumes of distributions. These are lifted straight from Peck, which is an excellent pharmacology book that you should all read and not leave reading till the last minute because you were scared of it, like me. So pancuronium, a very, very commonly used drug these days. It's highly charged and has a small volume of distribution, so into 17.5 litres or 0.28 litres per kilo. Although, interestingly enough, drugbank.com suggests that rocuronium's indexed litre per kilo is 0.2, so maybe we should have used rocuronium and not pancuronium, Peckenhill. The counter to this, the other extreme, is chloroquine, an antimalarial. It has a volume of distribution of 10,000 litres, and that's because it is sort of soaked up intracellularly and sequestered away, which makes it appear that it distributes into a far larger volume because of the measured concentration in the plasma once it's all been sucked up. So lots of talking. And now the most important thing is, what's the definition? I've said loads of stuff. So, volume of distribution is the apparent volume into which a drug disperses to produce a measured plasma concentration, i.e., if you give them 10 milligrams of drug X and then immediately measure the plasma concentration of drug X, and it is 1 microgram per mil, you can then use that to suggest how much space that drug has ended up dissolving into within the person. The formula for volume of distribution, there's two depending on how you look at it, but the crux is the volume of distribution is equal to the dose given divided by the plasma concentration at time zero, i.e. you give that dose in one vein and then take a sample from another vein. Technically at time zero, although as you can understand and consider as you drive, run, gym, or sit listening to my dulcet tones elsewhere, clearly you can't do it at time zero, because if you did, the distribution would be ridiculous because it might not have got round yet. So I would argue that an arm brain circulation time or two you would have to occur for you to be able to measure something, and then actually it's not time zero anymore. So that's why this is a concept and not actually something you can apply really. But as you'll come to find with a lot of the science behind anaesthesia, to actually truly explain how things work in a human being requires incredible levels of detail, and that's excessive for what we need, and that's why fudge factors exist. So to bring these concepts a little bit closer to reality in situations where we might use them, the one that immediately jumps to most people's minds is TIVA. So we're thinking about these models that try and figure out how much drug to give to achieve a certain concentration of the drug, either in the plasma or at a theoretical place, within the model at least, the effect site, i.e. your CNS. And these utilise pharmacokinetic data, volumes of distribution, but also the rates at which the drug diffuses from the plasma to the muscle, from the plasma to the fatty bits, but also counter to that, the rate at which the drug diffuses from the fatty bits back into the plasma, which vary depending on how full those reservoirs within the body are. So there's a number of transfer rates to and fro, as well as clearance from plasma into, for example, non-functioning metabolites, i.e. the exit point from your model. Another situation to think about, which actually is probably something you're going to be doing more of at the start of your training, is putting volatile anaesthetics into people, which also follows volume of distribution characteristics, and actually you can see it in action much more than a TIVA model, because you've got to get a certain amount of drug into several compartments. One of those compartments is your anaesthetic circuit, another compartment, patient's lungs, another compartment, patient's plasma, and another compartment, their brain, and their fatty muscly bits. And you can see how this works because they soak up SIVO real quick, and if you fill that circuit with plenty of SIVO, they'll soak it up faster. But as they're waking up, their MAC drops really quick because it dumps out of their plasma, dumps out of their brain and muscles. But then you get stuck at like 0.23 MAC for a bit, and it slowly ekes out because that's the rate at which the SIVO comes out of their fat compartment into their plasma, into the lungs, back into the circuit, and you're constrained to the diffusion rate from that final compartment. Unfortunately, that keeps your patient a bit anaesthetised for a bit longer. There you go, volume of distribution of a volatile anaesthetic in action with a compartment model that you can see and think about to try and manipulate to the best of your ability to try and wake your patients up faster or finish writing your notes. Now's the time of the podcast when we talk model answers, model questions. Remember, guys, I've prepared this. It's not off the top of my head, so don't stress too hard. Having a good grasp of these concepts is important, and here we go. Doctor, what do you understand about volume of distribution and how might it influence drug choice? Okay, hello. Volume of distribution is the apparent volume a drug rapidly ends up in or diffuses into at administration to a patient at time zero. It can be calculated by dividing the quantity of drug dosed divided by the measured plasma concentration at time zero. It could influence the choice of drug dose by enabling you to calculate how much is required to achieve a certain plasma concentration in a patient if you are aiming for a specific window of therapy. This comes about a little bit when calculating gentamicin, but isn't done in common practice. You could rearrange that equation into volume of distribution times the measured or your target concentration equals drug dose, and you could use that to work out the dose of the drug. This isn't really ever done. It's already sort of been done for us by people figuring out how much drug achieves how much level of hypnosis, but for the purpose of modelling how the drug behaves inside the human over longer periods of time, i.e. keeping them asleep, that's when it can be useful to think about it like that. So clinically, volume of distribution is not really used in a daily manner in its literal sense, but the concepts apply. When you give a drug, you have to think about how long it works for, how it redistributes, and what behaviour it might elicit in your patient. And you're thinking about that constantly, even though you're not thinking, well, what's my measured drug concentration versus the volume distribution? You have a feel for it, but being able to take that feel and put it down on paper in a structured manner, in a semi-scientific manner, is important. It's the stepping stone to thinking about the pharmacokinetic models of TIVA and how SIVO behaves in a human, amongst some other drugs. It's also interesting to think about the fact that you might have other sites of distribution that are extracorporeal. We've talked about circuits. You could think about the filter in ITU for kidney replacement therapy, or oxygenators in ECMO, or your bypass system. That could be an extra realm of space. It's also perhaps worth thinking about that if your patient exsanguinates, you've lost quite a lot of drug that's floating around in them. This is important, particularly in obstetrics, where you might need to give a second dose of antibiotic if the patient has done a spot of exsanguination and you need to redose them to make sure that you reduce the odds of infection post. So in summary, volume of distribution is a theoretical concept. It's used to crudely explore the notion that drugs soak into people in a varying number of ways dependent on the characteristics of the drug and the human. We could use it if we wanted to calculate doses and achieve therapeutic windows, although bear in mind that the concepts we've talked about here are only for single time points, so then it re-equilibrates and then it's useless again. If you want to go into a deeper dive, there's loads of pharmacokinetics looking at the volume of distributions graphed over time, which is the stepping stone into these TIVA models. So thank you all for listening. I hope volume of distribution isn't too heavy, and I hope I've managed to enable you to jump the gun on some of the awkward bamboozlements that I experienced, and you're in a stronger position to learn it more quickly now by listening to this. Thank you very much for listening. Please like, subscribe, click the appropriate buttons at your leisure to say cheers, and I'll see you for the next one. I think we're going to do pKa, another pharmacological concept. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.